identify the signs and symptoms of DVT, to understand or be familiar with the imaging and medical workup of patients with DVT, and then to identify the treatment options, whether that is medical, surgical, or endovascular. And then finally, to understand the nursing role in the management of patients before, during, and after some more invasive treatments for upper extremity DVT and lower extremity DVT. So I wanted to start the lecture with a case presentation. This was basically presented in the New England Journal of Medicine a few years back. So it was a case of a young female, 35 years old, who came to the ER with progressive left leg pain and swelling. She felt warmth in the leg, but she didn't have any fever or chills. She had some shortness of breath, but no chest pain. There was no recent trauma, no pregnancy, no prolonged travel. She was pregnant in the recent past. She was on a multivitamin daily as well as an oral contraceptive pill. So she came to the ER, got her left leg examined. There were no signs of trauma. She did have swelling from her ankle to the thigh. It was tender. It was slightly pale. The pulses were diminished compared with the right leg, but they were still palpable. And she had full strength and sensation in both of her legs. The rest of the exam was normal. Okay, so as part of her workup, she had a chest X-ray and an EKG, both of which were normal. She had an ultrasound, a Doppler ultrasound of her left leg, which showed sluggish flow in the iliac and femoral deep veins, inconclusive for thrombus. She underwent a VQ scan. She was young and otherwise healthy with a normal chest X-ray, which is the appropriate test. That's supposed to say CT pulmonary angiogram, which we all know is a CT-PE study. That was normal. So what would be the next step? I'll give you some options. You can do a venogram of the extremity and the pelvis just to try to identify the clot. So the options are an MR venogram, a CT venogram, which are both cross-sectional imaging studies, or a conventional catheter venogram study. This patient underwent an MR venogram of the pelvis. What it shows here, I'll try to find the arrow. This is a cross-sectional study. This is her right side over here, left side over here. This is the right common iliac artery, the left common iliac artery, the right common iliac vein, and where these two small dots are is the compressed, or essentially the non-visualized left common iliac vein. And then she has some collateral veins in the retroperitoneum on the left and in the abdominal wall on the left. So the patient went to interventional radiology. She underwent a catheter venogram. She is prone, so this is her left side, marked with the L, and this is her right side. So the way this test was done, she's on her stomach. They obtained access probably through the popliteal vein, put a catheter up through the, up the thigh, into the pelvis, and did a venogram showing that there's an occlusion of the vein here. There's a lot of collateral vessels present. This is a picture now with the patient flipped onto her back, so she's supine, so now the sides are switched. Excuse me, but she underwent TPA lysis of the clot, and this is a follow-up venogram showing that there's still a little bit of clot there, but now there's flow through the iliac vein into the IVC. And then this is after the patient underwent angioplasty and stent placement to open up the blockage or the partial occlusion here to get the vein back to a normal size. So this is what's known as May-Thurner syndrome, which you may or may not have heard. But what it is a condition where the left common iliac vein is compressed or pinched between the right common iliac artery and basically the lumbar spine. So as the vein passes between those two places, it gets narrowed, and eventually it occludes and causes lichen swelling, and at some point an acute DVT. It is an acute on chronic process. It does happen over time. It's probably something that people are born with. And basically the treatment is what was done there. So to do lysis, to open up the vein, and then do an angioplasty or a stent to get the vein back to a normal size so that the clot doesn't come back. A lot of people will go on to do a PE study, but essentially what happens here is you really can't get a PE because there's no way for the blood to go directly from the iliac vein into the IVC, into the right heart, into the lungs. So it's sort of a, the body is auto-obstructed the iliac vein. So when you see a young person, usually female, left leg DVT, that's pretty much diagnostic for May-Thurner syndrome in the absence of some other predisposing factor like trauma or recent surgery on the left leg or something like that. So just a review of anatomy. Veins have valves. They keep blood flowing in one direction, so they're not thick-walled like an artery that has the heart pumping it forward. It basically relies on veins to keep the blood flowing in one direction towards the heart. In the upper extremities and the head, gravity moves the blood back to the heart. In the lower extremities, muscle contractions move the blood back to the heart. So when the valve is open, blood can flow in one direction. The valve closes, and these valve cusps here prevent blood from backing up. Just some anatomy of the lower extremity veins. There's a superficial system and a deep system. The superficial ones cause varicose veins, cause thrombophlebitis, so that's a superficial problem. The deep veins are the ones we worry about causing DVT. So the deep ones in the leg, the popliteal vein around the knee, the femoral vein. It's also called the superficial femoral vein, but because of the word superficial, people don't know whether to treat it as a superficial thrombophlebitis or a DVT. So we try not to use the word superficial because it confuses people. So femoral vein, and then common femoral vein, and then the iliac has an external and a common, and that empties into the IVC. There are deep veins in the calf. It's debatable whether people need to be treated for those. The truth is the veins are small, the clots are small. If they do break off and go somewhere, they're probably not clinically significant, so people generally don't treat them. In the superficial side, we have a great saphenous vein, also called a greater or a long saphenous vein that goes from the groin to the knee or maybe the calf. The lesser saphenous vein is also called the short saphenous or the small saphenous vein, and that goes from the ankle up to the knee. So two different systems. We're talking about the deep venous system when we're talking about DVT. In the arm, similarly, there's a superficial and a deep. The brachial veins are deep. They empty into the axillary, then the subclavian vein, the brachiocephalic vein, and the SVC. The jugular vein and the brachiocephalic vein kind of come together to form the SVC, or I guess the brachiocephalic is formed by the jugular and the subclavian vein. The superficial side, you have the cephalic vein, which is pretty superficial and lateral. You have a basilic vein, which is very medial. So generally speaking, cephalic and basilic are superficial. Brachial, axillary, subclavian, brachiocephalic are all deep. The distribution of DVT, most of them are proximal, meaning in the thigh or pelvis. Calf and proximal is a good third as well. Isolated calf is fairly uncommon. Upper extremity is fairly uncommon, so it's about 80 or 90% are going to be in the legs, and about 10% are going to be in the arms. Others probably, some random occurrence like a gonadal vein or something that counts as a thrombus, but it's not necessarily treated as aggressively. So the epidemiology, so venous thromboembolic disease, or VTE, is a term that's used to sort of incorporate DVT and PE. They're kind of used interchangeably for the most part because they're treated the same. So a PE is just a blood clot that broke off and traveled to the lungs. They can be acute or chronic. They may be recurrent, so some people get repetitive or recurrent DVTs. And then venous thromboembolic disease, it can be debilitating in the long run, leading to chronic conditions such as pulmonary hypertension if you have chronic PEs, or at least one large PE that you survived, or post-thrombotic syndrome, which I'll discuss a little more. It's an expensive diagnosis. A lot of, it's a common disease, and it costs the healthcare system. The annual incidence, this is from a study in 1999, about 2 million DVTs annually. This is in the U.S. So if we look at kind of what happens to these, so maybe 40% or so, that's the right math here, will develop a PE, and then some of those will go on, to death if not treated. Silent PE, that's kind of what happens to people when you don't know what happened. Do they have a heart attack? Do they have a PE? Do they have both? So, it's a silent thing, so we don't know exactly, but this is a number that's published. PE, a small fraction, but not an insignificant number, will go on to develop pulmonary hypertension. Post-thrombotic syndrome, again, I'll talk about more, but that's a debilitating condition where the valves in the lower extremity veins stop working as a result of DVT. So, that's a fairly large number caused by DVT. The etiology, Virchow's triad, is what was taught in schools. It's sort of a triad. You have to have endothelial damage. You have to have a hypercoagulable state, and there has to be stasis of the circulation, of the venous circulation. Some risk factors for endothelial damage, so trauma, if the vein was stretched, ripped. If you have indwelling venous catheters, PICC lines, central lines, something where there's a foreign body in the vein that can sort of act as a nidus for clot formation. Venous stasis, basically, prolonged immobility, whether it's bed rest from recent surgery, recent trauma, whatever it is, prolonged travel, morbid obesity, sedentary lifestyle. If you're not moving, the muscles to compress the veins and pump the blood forward, it's set up for DVT. And then other things that can cause venous stasis by compression, extrinsically, May-Thurner syndrome, which is the case example that I showed you, that's in the lower extremity. Paget-Schroeder syndrome is another one of those strange names which you may or may not have heard. It's also called effort thrombosis or thoracic outlet syndrome. That happens in the upper extremity. I'll show you a case of that. This is where the vein is pinched, and because of that, the blood isn't moving forward. Malignancy is, obviously very common. So if you have a pelvic mass or pelvic lymphadenopathy that can compress the veins, or the IVC, that's a setup for stasis and DVT. So clinical features, so patients with venous thromboembolic disease, they may present with symptoms of DVT, so they may have leg or arm swelling, pain, discoloration. They may present with symptoms of PE, so they may show up with shortness of breath, tachypnea, or, classically it's a pleuritic chest pain when you take a deep breath. Clinicians need to have a high index of suspicion for DVT and PE. And obviously they do, because most ERs nowadays scan everybody that walks in the door for PE, maybe not DVT, but you can't get into the ER without a PE study these days. But if they have risk factors, so if they have cancer, that's a big risk factor. If they've said they traveled recently, they've been bedridden for a long time, you got to be on the lookout for those. And then proximal DVT, we talk about proximal being iliac, femoral, subclavian, so something where it's closer to the cava, closer to the heart. They're typically symptomatic because you're obstructing a larger vessel with more blood flowing through it. Calf vein DVT patients, they typically are not, unless they have proximal and calf. So physical exam, examine the extremity. It's useful to examine the contralateral extremity for comparison, especially for swelling, discoloration. Is there swelling? Is it symmetric, asymmetric? Pitting edema, is it tense? So if they're really swollen, the leg is big and the skin is tense. You can't even get it to pit because the skin is so tight. Discoloration, if it's purplish, it suggests a diagnosis of phlegmasia cerulea dolens. People call it phlegmasia. It just means that the leg is sort of mottled. It's become kind of dusky because the blood can't get out. The opposite of that is phlegmasia cerulea albans, which is white, and that happens when the blood can't get in. So that's a cold leg because of a blood clot in the artery or some arterial obstruction. The leg isn't swollen, it's just basically white. The purplish color and the swollen leg is more of a concern because it could be that the leg is now threatened. Blood can't get out, and it can become pretty serious because it compromises the arterial blood flow. So part of the exam is to check the pedal pulses. So are they palpable? Are they present but only Dopplerable? Are they absent? So these are things that may suggest that you need to do something a little more quickly if any of these are present as far as the phlegmasia or the pulse abnormality. Are there ulcers? You know, that may be a manifestation of a long-standing chronic venous process. Where is the ulcer? Is it on the dorsum of the foot? Maybe it's arterial. Is it on the medial aspect of the ankle? You know, it's probably venous. So here's some pictures of, you know, acute pain and swelling. So obviously in this patient, the right leg is much more swollen than the left. It's red. It's not necessarily purplish, but it's substantially bigger. This one, swollen, you know, not severely, but it is, you know, there's something wrong there. Now these are, you know, more chronic venous stasis changes. Medial ankle is the common site. So this is usually from venous insufficiency. Valves don't work, the blood pools in the foot, the hemosiderin deposits start staining the skin. You get kind of this brownish discoloration. The foot is kind of more purple, as opposed to the arterial changes are usually in the dorsum, and the foot is typically white because it's not getting enough blood. What are the consequences? So the mortality is more or less due to PE. So a DVT isn't necessarily going to kill you. A PE is. So what happens? An acute cardiac arrest, pulmonary hypertension, because maybe you have a saddle PE and the blood can't get out of the pulmonary artery. What are the risks of this? A proximal DVT, so something in the thigh or the iliac veins, in the pelvis. You know, if you have clot that goes into the IVC, if you have free-floating thrombus, typically in the iliac veins, there's a risk that this clot is going to break free and eventually get to the lungs, you know, to the heart and to the lungs. So these people, you know, maybe you consider a filter before you do anything because of the risk of migration to the heart. Morbidity is more typically due to DVT. So pain, you know, how bad is it? Is it tolerable? Same with swelling. You know, depending on how symptomatic the patient is, kind of influences what you're going to do about it. Can they not walk because they're in so much pain or they're swollen so much? Is their limb threatened because the arterial blood flow is compromised? And then kind of more of a chronic thing is the venous insufficiency and the post-thrombotic syndrome. So PTS is basically a condition which occurs when the valves in the veins stop functioning, usually as a result of a DVT that wasn't treated, not necessarily treated, not in the sense that it's not treated with anticoagulation, but if it takes a while for the clot to get out, the valves get damaged, they become incompetent, the blood backs up, and that leads to chronic venous insufficiency. So it's more discoloration, swelling, ulceration, pain. This is sort of a chronic problem. And once it gets to this point, there's really nothing you can do about it. There is talk of developing valves to see if you can get artificial valves, but to date, that's not really it's not available. I don't know that it will be for a while, but at this point, all you can do is offer compression stockings, support hose, just to reduce the swelling and help with some of the pain. So how common is post-thrombotic syndrome? So this is, you know, a study looking at all these. This is 2004. All these studies that were published to figure out how common is it. The numbers are kind of all over the place, but the numbers aren't low. So some of these 84%, 50%, 70%. So it does happen. 50%, you know, at 5 years is a number that I had kind of learned. At the end of the day, anybody who gets a proximal DVT is at risk for getting PTS. So, and it matters because once people get to the point where their leg looks like this, you know, there's nothing you can do about it. What else can happen? So a DVT can recur. So 30% at 8 years, looking at all these studies. This is 1996. But, you know, once you have a DVT, you're obviously at risk for getting another DVT. So you get your DVT, you get some anticoagulation, you stop it when the DVT is gone. You know, may get another one in the future. So in 2008, the Surgeon General decided to speak out to try to, you know, call to action to prevent DVT and PE. So obviously at that point it was recognized that it is, a serious problem with a lot of morbidity and mortality. It's kind of a health issue, something that more or less maybe can be preventable or at least treated appropriately. So how do we prevent it? So ambulation, the biggest risk, immobility, so ambulate more, exercise, get people up out of bed postoperatively. When they're in the hospital, TEDs and SCDs to the extremities to try to pump the blood. Prophylactic anticoagulation, heparin or low molecular weight heparin while they're in the hospital. Everyone talks about when you're traveling, what do you do? Well, you just kind of pretend like you're stepping on the gas while you're flying, or get up once an hour and walk around if it's a long flight. Hydration, if you're not hydrated, if you're dehydrated, we see a lot of people that get blood clots, and sometimes we can't figure out why. Well, maybe it's just that they were dehydrated and the blood's a little more thick or viscous. So how do we diagnose it? So clinical evaluation, imaging workup, laboratory workup, this is, all of these are involved in the diagnosis. And then what are the treatment options? Anticoagulation, thrombectomy, thrombolysis. I'll kind of talk about these a little bit more in detail. The imaging workup we kind of went through with that case example. The DVT ultrasound is pretty much what's done for everybody. The limitations, it's good for the extremities. It may not be able to tell you how acute or chronic a clot is. So if the vein is expanded and the clot is hypoechoic, the patient showed up with swelling, it's probably acute. If it's kind of marginal along the wall of the vessel, that's probably more chronic. So sometimes you can't tell. Like I said, it's good for the extremities, legs, arms. It's sort of bad for the evaluation of the abdomen, the pelvis, the chest. So maybe you can see an external iliac vein clot, but it's kind of hard to see a common iliac vein or an IVC clot. You might get up to the clavicle and see the subclavian vein, but it's hard to see beyond that into the brachiocephalic vein or the SVC. So, what do we do then? We usually do some other cross-sectional imaging study, a CT venogram or an MR venogram, just to see how high or how central it went. The reason is that it matters. If it goes into the iliac vein or into the IVC, then you're going to treat it more aggressively. You're going to think about putting in a filter because there's a risk for central migration and PE. Also, you can look to see, why did this happen? Is there compression of the iliac vein or the IVC from some tumor mass? Do they have May-Thurner syndrome? The other option is a catheter venogram. So, it is more invasive than these other two, but you can diagnose the thrombus. You can determine how centrally it extends, so the extent of it, and you also have the ability to treat the thrombus through the catheter. So you can try to remove the thrombus. You can try to dissolve the thrombus. Okay, so now as far as the clinical workup, the DVT is established. Now you got to figure out what to do with it. So, or what to do about it. A lot of that is determined by where the clot is, how extensive it is, what caused it, the patient comorbidities, how old is the clot? Is it acute? Is it chronic? So it's kind of a multidisciplinary approach. The hematologist typically does a hypercoagulable workup, so send out a bunch of tests just to make sure that they don't have something in their blood that predisposes that person to clotting. It's usually a send-out test. It takes weeks to get the answers back, so it's not going to help you treat them in the short term, but it will determine if they need to be on anticoagulation for life. Depending on how extensive the clot is, how symptomatic the patient is, the patient can be evaluated by a vascular specialist. So an interventional radiologist, a vascular surgeon typically. Essentially, if they have a threatened limb, that certainly is an indication for evaluation. But that being said, anybody with an acute DVT can be evaluated to determine if there's something that can be done. So, surgical thrombectomy used to be an option. It's not done so much anymore because catheter-directed techniques have evolved. So why do an open surgery to kind of fillet the vein open and get all the clot out when you can do the same thing through a small catheter, through the skin? If the patient has, a massive PE is defined as a PE that causes the patient to be hypotensive with a blood pressure less than 80. So, in that situation, the patient probably needs to be in the ICU, evaluated by a critical care specialist to determine if they need TPA directed into the pulmonary artery, either through a Swan-Ganz catheter, through a peripheral IV, or do you have somebody put a catheter up into the pulmonary artery and try and dissolve the clot to get the blood flowing to the lungs again. So I'm not going to talk about PE management so much today. It'll be more of a focus on DVT, but if anybody has questions, we can talk about it. So what are the treatments for venous thromboembolic disease? And again, I'll kind of focus more on DVT, but the conservative or the medical treatment has always been and remains the gold standard systemic anticoagulation. Typically 3 to 6 months for a DVT, 12 months for a PE. You get the hematologist involved, they're ultimately going to make that decision, but that's the gold standard. Aggressive treatment, surgical or endovascular, involves clot removal or TPA administration to try to break up and dissolve the clot. Again, the treatment's determined through a multidisciplinary approach, and it depends on how symptomatic the patient is and how big the clot is. So is anticoagulation alone adequate? So, looking at this study from '97, 50% of basically, pain in their legs because of backup of blood. 95 are different studies, but a lot of them will develop valve incompetence, PTS, leg swelling. So if you just do anticoagulation, a lot of people down the road are going to develop chronic stasis problems. What about large clot burden symptomatic DVT? So if they have a lot of clot, the entire leg, the pelvis, both legs, anticoagulation alone is going to be pretty limited in getting rid of the clot. Eventually it'll happen, but maybe it's going to take 6 months, a year. If we do a study here said if we did a venogram in patients that just got anticoagulation, I don't know the exact time frame after it, but a lot of people, the clot was noted to extend, and there was either no evidence that it went away, it didn't go away, or it started extending. So it wasn't necessarily a good thing. Eventually it works, and it's not invasive, but is it enough? A major risk of a proximal DVT is PE, so if we don't anticoagulate people, 50% are going to get a PE. If we do anticoagulate them, 21%, or a fifth of them, will get a PE. So is that enough? How about preventing post-traumatic syndrome? So the extremity sequela, which I showed you pictures of, talked about, it's directly related to the presence of the clot, and the clot being the potential for valve damage. So anticoagulation doesn't promote rapid recanalization. It doesn't remove the clot and restore flow into the blood vessel. Clot removal does. And by removing the clot, that helps preserve the valve function. So what are the treatments that are offered for DVT? So 1994, so 20 years ago, catheter-directed thrombolysis was developed, or at least was the practice started. So this is a study showing, if we put a catheter into the clot and dissolve the clot, giving TPA through the catheter over, hours or days to try to get it lysed, they found complete lysis in 72%, partial lysis in 20%, and no lysis in 8%. They found an underlying stenosis in a lot of them, which required stent placement. This is a different study, kind of a larger study that showed if we took people with clots, did catheter-directed thrombolysis, and looked for patency afterwards, basically a lot of them got clot resolution. This time frame is 12 months, but more than half got the clot out. So they also looked at the complications. So major bleeding occurred in 11% of those patients. So, puncture site bleed, internal bleeding, or a intramuscular hematoma went in the leg, and then intracranial bleeding was 0.4%, which isn't zero, but it's not, this isn't without risk. And then these studies looked at patency and symptom resolution if you did standard therapy versus if you did lytic therapy, right? So 80% are going to get symptom resolution if you do lytic therapy, as opposed to only 20 to 30% if you do standard therapy. 80% or so are going to have 6-month patency if you give them lytics, versus only about a fifth if you give them anticoagulation alone. So again, anticoagulation is and always has been the gold standard, but the question always is there something else that we can do, something better? So this is an example of catheter-directed thrombolysis, a 33-year-old female who had right arm swelling. She had acute DVT diagnosed by ultrasound involving the brachial, the axillary, and the subclavian veins. So this is a venogram, the patient's right arm. We're coming in from the right side, injecting the brachial vein, and you can see centrally, I don't have the bone pictures here, but her clavicle is here. This is clot here. Another picture showing, in sort of a delayed phase, showing all these collaterals that develop because the vein is being pinched here. So we put her in a catheter, we inject TPA through the catheter, over the course of a day and a half, whatever it is. Bring the patient back, and most of the clot is gone, not all. You had the patient raise their arm, so kind of put their arm up in the air, and now you see that the vein is pinched again. Now you raise the patient's arm back down after further lysis, and the vein is open again. So this is a condition called Paget-Schroeder syndrome. It's one of those things that it's a mechanical obstruction. The clavicle and the first rib pinch the vein as it passes into the chest. It usually happens with repetitive overhanded activities, so waiters, baseball pitchers, swimmers typically. It doesn't have to, but that's kind of classically who it occurs. When the arm is raised up in the air or abducted, that's what pinches the vein. Basically, you treat the acute occlusion, because arm clots can be very symptomatic. I mean, we notice swelling in our arms much more than our legs, so those patients need to be treated a little more aggressively. You lyse them. After the clot's removed, they go in to have surgery to remove a portion of the first rib. You may have to bring them back to do a venogram, because what happens is this narrowing here with the rib in place, we can't use a balloon to open it up because the rib just keeps the vein pinched. Once the rib's removed, the vein is kind of scarred, but we can use a balloon or a stent to open up the vein so the clotting doesn't happen again. So going into some more, some of the details about how we offer this catheter-based treatment. So, a patient is in the workup for something like this. They've gotten to offer them the therapy. Let's just double check to make sure that there isn't a contraindication to the treatment. So the treatment involves putting a catheter in the vein, injecting TPA locally into the clot. Some of it does get into the systemic circulation, so you have to be careful, because the biggest risk of this is bleeding. So is there a contraindication to TPA? So typically speaking, if somebody has an intracranial mass, metastatic disease, something that's going to potentially bleed, you're not going to do it in that patient. If they've had a history of an intracranial, you probably don't do it in that person. If they've had recent major surgery, there's a list of these. It's kind of like TPA administration for stroke. You have a checklist of people that can't get this because the risk outweighs the benefit. Do they have an IV contrast allergy? Do they have renal impairment? So we have to give IV contrast to do this. In those patients, maybe it's say, let's be conservative, just offer them the standard of care, which is anticoagulation, maybe, and a stocking to prevent swelling. The patient can undergo systemic anticoagulation, so it's not a contraindication. You can say start the heparin drip, start the Lovenox, start the whatever it's going to be. You don't need to stop it for the procedure. So we want the blood thin. It helps us get more of the clot. Before you start this, you want to think about, does the patient need a Foley? Does the patient need a PICC line for blood draws? Generally speaking, once you start TPA, you're not supposed to do any IV or IA punctures because there's a risk of bleeding. You don't want to do any catheterizations, again, because there's a risk of bleeding. So it's one of those things where think about it, and everybody, is it practical? No, not really. If you have a gentleman who's got a history of urinary retention, you might want to consider it. If you have a young female who wants nothing to do with a Foley, you just say, okay, then you're going to need to be, you're going to be in bed for the next 24 hours. You probably, do you want to get on and off a bedpan, or do you want us to sedate you, put a Foley in? I kind of leave it up to the patient. is a filter indicated. So in a patient with May-Thurnes, where the vein is basically compressed, there's nowhere for the clot to go. That patient doesn't need a filter. If they have clot extending all the way up into the IVC, you probably want to put a filter in, because as you dissolve this, some of it may break off. Or as you cross the clot to do the lysis, maybe you push some of it forward into the heart, into the lungs. So does that patient need a filter first? Something just to think about. The procedure itself. So depending on the clot that you're treating, if it's an arm, if it's a leg, you basically obtain venous access into the extremity. So in Paget-Schroeder, in the arm, you probably get access into the brachial vein, the basilic vein. You put in a sheath, generally speaking, 6 French to 8 French size. You perform a venogram to identify where the clot is. Give them heparin just because you want to keep the blood thin. You position your Lysis infusion catheter across the clot, and the catheter goes through a sheath and then across the clot, so that you're kind of spanning the clot, and the tip of the catheter should be beyond the clot. You can infuse TPA through the catheter, so the rates of infusion are kind of position dependent. The published rates, generally speaking, anywhere from 0.5 to 1 milligram an hour, and you kind of leave it there, let it go for 24 hours, 18 hours, depending on when you start the case, when you want to see the patient again. The purpose is to dissolve the clot, locally administered into the clot, but again, some does enter the central circulation. You infuse heparin through the sheath at a low rate, 500 units an hour is what I typically do, for the same time that you're treating the patient. It's a low-dose infusion. It's not therapeutic. You don't need to measure the PTT. The only purpose is to keep the sheath open, so that you're trying to dissolve the blood, not form new clot. This is a picture of a patient as they are ready to undergo the procedure. So the patient's on the angio table. This is a leg clot. So leg clots we usually treat through the popliteal vein behind the knee. Occasionally you have them on your back. You start in the groin, you go up and over to the other leg. More commonly, you treat from the popliteal vein and go centrally into the IVC. So this patient's on his stomach. The picture is a little small, but the patient's draped. You have the II here. You have an opening in the drape for the, behind the knee. This is a picture showing the popliteal fossa. So we use ultrasound to get into the vein. It's a local procedure, so we put, lidocaine in to numb the skin. Usually we give them conscious sedation because they're going to be laying there for a while. We put a sheath into the vein. We put the infusion catheter through the sheath. This is just as the procedure goes on. So basically it's done like an angio of the venous system. So after you secure the catheter, the patient basically has to be observed in an ICU setting or at least a step-down setting. The reason is, they are at risk for bleeding. So TPA is a very potent drug. They have to be monitored for access site bleeding. They have to have monitoring for intracranial bleedings. I've had patients with nose bleed. So basically, I have them keep that extremity straight. They're usually in bed rest, vital signs routine, whatever the ICU routine is. At the same time, check the access site, do a neuro check the pulses, make sure that everything is okay. We drew serial hemoglobin and hematocrit levels basically every 6 hours, along with serum fibrinogen levels. The reason is, as the TPA breaks down the clot, the only way to measure the activity is through the fibrinogen. So we usually get a baseline before we start the case. We check it every 6 hours. If the hemoglobin, starts to drop significantly, if the patient has a headache, if the patient has, severe back pain, or when the fibrinogen level, I usually have them call me when it's less than 200, but typically speaking, if it drops to less than 150, the treatment is to decrease the rate by half. So if it went, if you were doing 1 milligram an hour, you drop it to 0.5. When the fibrinogen gets below 100, they are at risk for bleeding, so you usually stop the TPA, and then you just infuse saline through the catheter. You can keep the heparin going through the sheath just to keep the sheath open until you bring the patient back for the follow-up venogram. A typical dosing pattern is maybe 1 milligram an hour for 12 hours, then drop it to 0.5 milligrams for another 12 hours. If you have patients with bilateral DVTs and you have 2 infusion catheters, you probably do 0.5 or so through each. And then the patient returns to the angio suite for a follow-up venogram the next day, or if you start in the morning and bring them back at the end of the day, whatever the lab preference is. If there's a lot of clot, then maybe you lyse them for another day, or at least another 6 or 8 hours. If the clot is gone, then you try to figure out why did it happen. Was there some venous compression or narrowing or obstruction? Do you need to do an angioplasty? Do you need to do a stent so that the thrombus doesn't recur? Basically, when you're done, you take the catheter and the sheath out. You hold some pressure. It's a small skin incision that the sheath goes through. I usually put a gauze and a tegaderm so you can see if there's bleeding. And then I typically put on a TED stocking up to the thigh and an ACE wrap. So this is how patients usually, when I'm done, will look. They'll have their stocking on up to their thigh, usually maybe a little higher, and then wrap the leg with an ACE wrap. And this is just to prevent, it's to reduce the swelling they have and to keep the leg compressed so the clot doesn't come back. The patients, basically after they get off their bed rest precautions, which I usually have them in bed for about 4 hours after, just to make sure they're okay. I try to tell them to elevate the leg if they have significant swelling, because that's the only thing that's going to really help get the swelling down. Remove the bandages in 2 days. I usually have them wear a compression stocking, maybe the one that's from the hospital, the TED hose, for 2 weeks. This is just for symptom relief. They're usually going to be on systemic anticoagulation for 3 to 12 months, depending on if they have a PE, and that's to prevent the DVT from coming back. And then I usually see them in the IR clinic for an ultrasound in 3 months to make sure that the vein is still open, that it didn't re-thrombose. If they develop swelling sooner, we can always do an ultrasound sooner. We can always treat them again. So once you lyse the clot, ideally the clot is gone, it doesn't come back. Occasionally it comes back. So if there's a patient, with the Paget Schroeder case that I showed you, where they still have compression of their subclavian vein by the 2 bones. So the clot is at risk for coming back until that bone is removed. So that patient, until they have surgery, there's sort of a setup for clot recurrence. The advantages of the clot, the catheter-directed TPA thrombolysis, the clot resolves in days, not in months. And then the big advantage is that it reduces the long-term sequelae, so the post-thrombotic syndrome and the swelling. The disadvantage is an ICU stay. There are high doses of TPA that can be administered, especially if you infuse for more than 1 day. So back in the day, people used to do infusions for 3 days, and the reason, the 0.5% quoted risk of intracranial bleeding from this is from, when people were doing it 3 days in lysis. Nowadays, we usually don't lyse for that long. I usually lyse overnight and then decide, is there something else that I can do to try to get the clot out? It only works with acute or subacute clot. So we only really offer this treatment for people that have had a diagnosed clot less than 2 weeks old. So chronic clot sticks to the wall, it doesn't come out. So that's why you want to try to treat the clot, or at least recognize that you can treat it early as opposed to late. So the evolution of DVT therapy, so surgical thrombectomy was kind of the thing to do a long time ago. IV thrombolysis, that's a lot of TPA going into the whole bloodstream that is a setup for bleeding. Catheter-directed lysis, you just put the TPA into the clot. And now the newer thing is pharmacomechanical catheter-directed thrombectomy and thrombolysis, which is a mouthful. We call it PMT. That's a device, there's a few devices on the market where not only do we give TPA to try to dissolve the clot, but we also try to use a mechanical device to extract the clot. Basically, similar to catheter-directed thrombolysis for a leg DVT, we go into the popliteal vein or maybe the opposite femoral vein. For an arm DVT, we go into the silicobrachial vein, same sheath size. Typically speaking, this is a single session treatment. So if they have clot but not too much clot, this is something that can be done in sort of a one-setting process. Or if you do lysis, you bring them back the next day. They have some clot left, not a lot, but you really don't want to lyse them for another 24 hours. you offer this kind of catheter-based mechanical treatment. So some of these devices you may have heard of. There's others, but the three most common ones are the angiojet, the trellis, and the ECOS device. They work a little, by different principles. The angiojet device basically are these high jets that create kind of a vortex effect where the TPA in the saline is sort of, injected into there. Then you use heparinized saline and kind of flush it up to create these currents that breaks up the clot, and then you suck the clot out through the catheter. If you do this, and kind of let the person go overnight afterwards, it does cause hemolysis, so they may drop their hemoglobin. It may cause hematuria, so just warn the staff. They may develop orange-colored urine. It's something that they should know about because people get a little bit freaked out by it. When used in vessels near the heart, it can cause arrhythmia. So I've treated, clot in the portal vein where the patient, basically went asystole. So if it's a central clot, you have to be cautious because it can happen. You're not supposed to use it in the IVC, the pulmonary artery, these types of places, SMA, SMBs, clinically, because it can happen. I don't know why. The physiology is beyond me, but it's a mechanical or an electrical thing that interferes with the cardiac conductivity. So good for legs and arms, not so good for IVC and central veins. This is a trellis device. It's called an isolated thrombolysis catheter. So basically, the device has two balloons that sort of trap the clot. You infuse TPA into this segment. The balloons keep the TPA from going anywhere. It keeps the dissolved clot from going anywhere. And there's a sinusoidal wire that, this is a little battery-powered device. You basically put it in over a wire. You blow up the balloons. You inject the TPA. You turn on the device, and this wire just spins back very fast. You can control how fast you want it to go. And you treat it for maybe 10 minutes, maybe 20 minutes. Put about 10 milligrams of TPA in, turn it on, let it kind of just chew up the clot, and when you're done, you suck the clot out. This is a depiction of kind of the device as it's moving rapidly. When you watch it on the screen, you can see the sine wave going up and down. You can change the direction so the wave goes not just one direction, but the other direction. So it's a neat, pretty neat device. It comes in 15-centimeter lengths, 30-centimeter lengths. So you may have to do overlapping treatments. So now you're talking about giving somebody 20 milligrams of PPA instead of 10, which is a high dose, but the PPA is basically trapped between these two markers, so it can't really get into the bloodstream. Inevitably, some probably does, but not a lot, or not enough to be clinically significant. This is an example of using one of these devices. A 50-year-old guy, he came to the ER with massive leg swelling and pain. He was placed on a heparin drip overnight. The next day he came for a venogram and a trellis device. So this patient, venogram showing clot all the way in the femoral iliac veins, all the way up. Here's some flow in the IVC. This is a device with the balloons in place, so a central balloon, a peripheral balloon. Now you infuse the TPA, turn on the device. There's a little bit of clot left over. You see there's a narrowing of the vein. You put a stent in. Now you have good return of blood all the way through the occlusion back into the IVC. So again, the benefit of this is maybe it's a 1-hour treatment, maybe an hour and a half. The patient is basically clot-free the same day. So the preparation, the setup is essentially the same as with catheter-directed thrombolysis. The benefit, the patient can actually go home the same day, or maybe you keep him or her over for one night, send him home the next day. Advantages, they don't have to go to the ICU, assuming you get all the clot out. It's localized TPA dose. It's not getting into the bloodstream. You're not infusing it over hours and hours and hours. It can be done as an outpatient, or they go home the next day, and it's convenient. The disadvantage, it takes longer than just putting a catheter in and letting it dissolve in the ICU overnight. The on-table time, involves sedation time, radiation time, contrast exposure. There is no randomized controlled trial evidence saying that it is better than the standard of care. We like to think it is because we're getting the clot out, and we're keeping the valves functioning. It may require a stay if you don't get all the clot out. Again, just like catheter-directed thrombolysis, it's only for acute or subacute clot. So indications for this kind of treatment. What's accepted? If somebody has, a cable occlusion or a threatened limb, that's an accepted indication. You have to debulk the vein, get the clot out to restore the blood flow. Non-urgent therapy, this is sort of an evolving indication. So relieve symptoms, prevent PTS by keeping the valves functional, improve, early and late quality of life, so reduce morbidity. So it's not urgent, but more, that's something to think about for this reason. This is an example of somebody who had, an urgent indication. They had an IVC filter in place, the filter clot or thrombose. Now they have clot in both legs. So put a lysis catheter up. Here's some clot. This amount of clot, you probably want to lyse them for a while because there's a lot of clot there. Bring them back the next day, see what's left, see if you have to put a stent in, for further treatment. This is somebody who had a threatened limb. So you do a venogram, you see no blood flow going up into their pelvis. The iliac veins are completely occluded. They had phlegmasia. Similar case to the other one. You open up you use a Charles device to try to open up the flow. See that there's an underlying stenosis, put a stent in, and patency is restored. So the treatment indications are evolving. In 2004, they said you can't do catheter therapies, they're not supported by adequate evidence. In 2006, the SIR said, well, why don't we consider it for patients that are at low risk and they're ambulatory, so they can get up and walk around for iliofemoral clot only. In actual practice, what do? Well, if somebody has an acute or subacute axillary flavine or an arm DVT or a proximal leg DVT, those patients should be offered the therapy. The second line salvage, if they have clinical or anatomic clot progression. So if you put them on Coumadin and a week later they don't feel better, the swelling's getting worse, the clot is now in their pelvis, that's sort of a second line salvage therapy. First line is adjunctive therapy in addition to systemic anticoagulation to expedite symptom relief and decrease PTS. In 2008, the American College of Chest Physicians, their treatment guidelines for DVT is systemic anticoagulation, stockings, ambulate. They say recommend pharmacomechanical thrombolysis in select patients with extensive acute proximal DVT, symptoms less than 14 days, good function, long life expectancy, and who has low bleeding risk, and offer it to reduce acute symptoms and prevent PTS if the expertise and resources are available. So the therapies have evolved. It went from, just to Coumadin to maybe offer this, we don't know, to if the patient is, young or otherwise healthy and symptomatic, it's something that should be considered if it's offered at your institution. This is the patient that actually came into this hospital yesterday. So he's 52. He had an acute right leg DVT. He had swelling for 2 days. I saw the patient. His swelling wasn't bad. He had some pain, but his leg wasn't that much more swollen than his other leg. That being said, he's 52, and if you tell him, 50% of the time in 5 years, you're going to have non-functional valves with maybe some stasis changes, venous insufficiency, pain, swelling. I said, we can just put you on Coumadin, hope for the best, put a stocking on your leg, or we can do this procedure to get the clot out and see how you do to prevent long-term consequences. So he wanted to go through with the treatment. So we go into the back of the leg in the popliteal vein. You can see that there's clot in this vein all the way up the thigh. There is some collateral flow getting back centrally. You put a catheter through the clot, inject contrast beyond the clot. His iliac vein looks okay. His IVC is okay. We put an infusion catheter in. It's a multi-side hole infusion catheter. There's a marker here just beyond the sheath where the tip, the peripheral tip of the catheter is in the popliteal vein. The central tip is up here in the iliac vein beyond the clot. This guy, I just lysed him overnight. He came in late yesterday, so we said, well, let's just lyse you overnight, see how you do. He came back the next day. I just realized as I was loading this that when we take images from PACS, at this hospital, when stat studies show up on PACS, it lets you know. And I happened to snapshot this photo exactly as that warning came up. Sorry about that. But here's the sheath. Here's the wire. We inject contrast. Now the vein's wide open. It goes straight up the popliteal vein, the femoral vein. The iliac vein looks good. So, you know, this was one night at TPA. I didn't have to do any thrombectomy. I didn't have to do a balloon angioplasty or a stent. So this guy's clot-free, and now, you know, you put an H-wrap on him, a compression stocking, send him out the door on a Coumadin, and, you know, he's clot-free. So do you treat everybody? So this is a guy that came here about 2 weeks ago. He said, well, I had swelling for the last few days. I've never had a DVT before. The swelling's getting better, but the ultrasound showed an acute clot. So put the patient on the table, accessed the thrombosed popliteal vein, did a venogram, and there's all these funky channels that you typically see in a chronic process. So usually when there's an acute clot, it looks like, you know, something like this, where you can see big chunks of clot in the vein with some, you know, a little bit of flow around them. This was sort of, you know, the vein's real small here. There's all these extra channels. This is higher up. You know, it looked like it was okay. We said, I don't know if this is acute or is it acute on chronic. I'm not really sure. But why don't we lyse you? You know, I gave him the option of doing nothing or trying the lysis. That, you know, the risk of bleeding in the head is 1 in 200. You know, it's not 0, but it's pretty low. We watch you, and if you have any signs that there's bleeding, we shut, you know, the TPA off and see what happens. So he came back the next day, and the venogram essentially looked exactly the same. So the vein didn't get any bigger. It didn't get any more wide open. He still had all these channels. There was no clot in his common femoral vein. So this was sort of a, you know, this was a case where we got fooled into thinking that the clot was acute, when in fact it was essentially chronic. Maybe one of these, you know, collateral branches acutely occluded and caused some swelling. I'm not sure, but there's nothing we can really do. We're not going to make the vein a normal size, you know, beyond this. So he's got mature collaterals. It's over 2 weeks old. I put a stocking on him. He went on Coumadin, and that was the end of it. So it's not for everybody, but you know, what are we trying to accomplish when we treat DVT? So we want to achieve, what we're going to do, we want to achieve it safely. So we want to decrease the mortality due to PE. So we want to anticoagulate people. If they have a central clot, maybe we want to put in a filter. We want to decrease early morbidity, like swelling, pain, compression stockings, ambulation. You know, that accomplishes the swelling and pain palliatives. And then how do we decrease the late morbidity? So we want to preserve valve function, reduce the risk of PTS and chronic venous insufficiency. By doing that, treat the clot, get the clot out, debulk the vein, restore flow through the veins, and keep the valves intact. So kind of a wrap-up here. So venous thromboembolic disease is common. You know, it has early and late morbidity and mortality. So DVT and PE is not without, you know, bad things that can happen. The gold standard is systemic anticoagulation, which everybody should receive. Catheter-directed treatments, they can, you know, alleviate the symptoms, they can remove the clot, and they can prevent PTS. Is it for everybody? No, but you know, if you don't treat it, you're not gonna basically reduce the risk of these things. At least think about it. So, for me, I sort of say, you know, if it's an arm clot, you know, with the exception of a clot caused by a PICC line or something, you should treat that. You know, arm swelling is pretty debilitating, especially if it's, you know, your right arm and your right hand dominant. So arm clots, for the most part, unless there's a good reason why it happened, that person should get lyse. Any young person, you know, not pediatric age here, but any young person who's functional or fairly functional should get the option of having the clot removed. Why? Because you're reducing something that could potentially happen in the future and be debilitating. Older people, you know, if they're functional, if they don't have risk of bleeding, give them the option. You know, if somebody has cancer, brain mets, you know, those kinds of people, you're not going to treat them. You can get consulted to at least offer it or talk about it, but at the end of the day, you have to take each case separately. But if you don't think about treating it, it's never going to happen. So, it is beneficial in most people. You can get the clot out in most people, but it's not without risk. So it needs to occur in a supervised setting. The ICU staff has to be familiar with how to monitor these people as far as, bleeding is the biggest concern here. So are they hemorrhaging at the access site? Are they having a headache? Is there a risk that they're getting some bad news from this? So you have to notify people on how to care for them. But if you have the appropriate resources and the expertise available, it is something that is being offered more and more. So, what I do here at this hospital is I try to tell the ultrasound techs, if you have somebody and you find a clot, let me know. I'll be happy to call the referring doctor. I notify the ER staff, hey, we can treat people, people with clots. So if you get a patient that walks in with a clot, give me a call. It may not, the patient may not be a candidate, but at least we can talk about whether they, can benefit from it. Thank you.
I have a question that I think two-part. One is there FDA approval, and two is for the PNT?
Yes.
And two, is there an increased risk of PE with the PNT versus your regular TPA methods?
So the first part of the question, I don't actually know the answer to FDA approval, so I should, and I'll look into it. But in IR, a lot of the catheter-based therapies that we do, they're not FDA approved. So the devices, are on the market. Most of them do get approved for some indication or the other. The Trellis device, for example, I believe is approved to treat proximal clot, so iliofemoral clot. That being said, I'd use it to get clot out of an occluded TIPS. So is that indicated, or is it FDA approved? No, and that's sort of an off-label use. So a lot of what we do in IR is off-label. So we take one device that's approved for one application and use it for another one. A lot of the stents that we put in the body were approved for biliary use. So you put a biliary stent, a wall stent or something in somebody's iliac vein. Is that, approved? No, but it's one of those things where, it's been used over and over again with good results, and we're doing it, not because we're trying to be cavalier, but because we believe it's going to help the patient. So an angiojet, similarly, is used often in the arteries. Is it for the veins? I believe it has application or FDA approval. I don't know the official answer. As far as the clot migration risk or the PE risk, it's kind of I kind of look at it on a case-by-case basis. So the benefit of the Trellis device is that you put up a balloon, an occlusion balloon, beyond the clot. So the device isn't indicated for use in cable clot, mostly because the balloon isn't big enough to occlude the entire IVC. So, it's great for use in the thigh, the femoral vein, the common femoral vein, maybe the external iliac. It's not great for treating common iliac vein or IVC thrombus. It's just not big enough. So those patients I generally lyse because there's such a large clot burden. I'd rather let the TPA do the work for 24 hours, and then you have less to deal with when you come back. So if a patient with a low cable clot or a high iliac clot, I usually put a filter in before we start the case, and then take the filter out when we're done with everything.
Oh, right then and there.
Yeah. Okay. So maybe the hard part about that is you have them on their back with a jugular access for, a filter placement, and then you got to flip them over onto their stomach for a popliteal access for the treatment. So technically it gets a little bit, it just makes the case longer, but that's something that is done fairly commonly. The angiojet device doesn't have a means to prevent things from going distally. You're treating into the clot and kind of chewing up the clot as you go forward, kind of like Pac-Man. So yes, there is a risk. So I usually give them a heparin bolus before I start, because say they get a PE, well, what are you going to do for it? You're going to give them heparin. Okay, well, we just gave them 5,000 heparin. If the case takes longer than an hour, I'll re-bolus them every hour. If I know they have an extrinsic venous compression, like a May Thurner, like a Paget Schroeder, I don't need to worry about clot going anywhere because, like I showed in that picture, there's nowhere for the clot to go. So the vein is compressed to the point where no blood is flowing through it. So, I don't worry about clot migration in those people. So it is kind of a case-by-case basis. Yes, it can happen, but you got to consider where the clot is, and if you're concerned, put a filter in.
Well, one of the questions had to do with the filter on our online question. I understand you said that you would take it out probably after the case, but there are some instances you may decide to leave it in, like maybe the May Cerners or more complicated. Have you ever, what would be the requirements that you're sort of thinking in outlining just temporary filter once they get anticoagulated versus a permanent filter?
Yeah, for the most part, I tend to put retrievable filters in everybody. Yes, they're more expensive, but unless you tell me there's somebody who's 80+ years old with cancer and a 6-month, expected life expectancy, fine, I'll put in a permanent one because it's not going to come out. But for the most part, for these people, you go through the process of getting the clot out. At the end of this, you're hoping that they're clot-free. So maybe you could leave it in for a few weeks, maybe a few months, just to be safe. But you've essentially made them, they don't need a filter anymore. Is for the most part, these treatments are done for proximal clot. So from where you access the vein centrally. So can we treat the calf clot? No, the calf veins are too small. So what you want to do is open up the big veins, leave the clot in the calf veins, and let the heparin, the Coumadin, whatever they're going to be on, get rid of the calf vein clot. And then generally speaking, filters are good for clot over 3 millimeters. Most calf veins are less than 3 millimeters, so could, a long worm thrombus break out of the calf and go to the heart? Yes, it could, but for the most part, if you wanted to leave the filter in until the calf clot resolves, I don't think anyone would fault you, but I'd probably have the goal in mind that I'm going to put in a temporary filter, bring the patient back in a month, maybe do an ultrasound, make sure the DVT is gone, the calf vein thrombus is resolved, then take it out.
I'm sure PE would factor into those decisions too.
Yeah.
If they had.
Yeah, if they had a PE already, say you get somebody who had a PE, they're having a hard time breathing. It's one of those soft indications for a filter where you're afraid that if they get one more clot to their lungs, they won't survive. You put in a filter. That patient, maybe you leave it in a little while longer because, maybe they had a submassive PE, and we don't want anything getting to the lungs.
Okay. Do we have any questions in the room?
You typically have a patient that you infuse TPA. What if they're on plastics to use?
The question is about Plavix.
Yeah, aspirin, Plavix. So, when we put people on TPA, they're not supposed to get any other anticoagulation for 24 hours while the TPA is infusing. So the heparin that I give through the sheath, it's not therapeutic. So it's just a drip to keep the sheath open. Aspirin and Plavix, I guess I don't worry about it so much because you'd have to stop those medications for more than a day, if not 2 days, to Plavix 5 days. It depends on how symptomatic the patient is. If they come in and they're symptomatic, you're probably not going to wait 5 days to do the procedure. So I would just say, you could say hold it for a day, but at that point, the Plavix medication is already in their system. So I kind of don't worry about it. If they're on Coumadin and this happens, obviously it's not supposed to happen that way, but if somebody is super therapeutic or has a high PTT or a high INR going into this, I'm not worried about the catheter, the PMT part of it, but I'd be a little worried about doing a TPA drip because they're already, there's something wrong with their anticoagulation balance if they're, super therapeutic but pro-thrombotic. So I don't know what would happen, but I probably wouldn't want to lyse if somebody had an INR of 3. I just think that the risk of intracranial bleeding at that point isn't 0.5. You can't tell the patient it's 1 in 200. It's probably a lot higher. But I don't worry about that. When we get to the clot out and do the venogram, and then try to figure out, is there some obstruction of the vein that causes this to happen? Maybe they need cable reconstruction. Maybe they need stents in the iliac vein. So it's not uncommon that we do all this and we figure out the reason this clot happened is because they have a stenosis of their iliac vein. So, we put in a stent. Those patients I usually put on aspirin. Some people put them on Plavix. It depends on who you ask. To me, iliac veins are fairly big. It's like a 12 millimeter, 14 millimeter stent you're putting in. I think an aspirin alone is probably enough just to keep that stent open. It's not a coronary stent, a renal stent, 3 millimeter, 5 millimeter stent that you're worried about. So I, generally speaking, will put them on an aspirin plus Coumadin or whatever it's going to be for 3 months, and then just keep on a baby aspirin for life. Some people might put them on Plavix for, it's just a person dependent.
Okay. There are no more questions online either, but I do want to say, for those of you who might not have joined us at the very beginning, this has been recorded, and we're going to have it on our website within the next week. We have a way of now adding that onto our website. So email myself, Karen Marshall, or Mike Wilson for that information in the future. Just to reiterate the announcements from the beginning for those who were late, Glarrin is sponsoring a CRN review exam on June 22nd and 23rd. It was in our newsletter, and we will have more information to follow as the dates approach. So look for that. We had as long as there's no more questions, I think we'll go ahead and close. And thank you so much, Dr. Sherman, for
thank you, everybody, for having me.
giving us your time.